Hello, my name is Harry. I'm one of the clinical managers at the Mesa Clinic. And as you know, the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders came out about 2 years ago. But what you may not know is that the Department of Behavioral Health Services has mandated that all providers incorporate DSM-5 into their clinical medical record by the 1st of October. You also will remember that about a year ago, a young lady from Ottawa University came out and gave a presentation on DSM-5. The purpose of this video is to reintroduce you to some of those concepts and highlight the changes that will be made and most apparent to you as we progress from DSM-4 to DSM-5. So in this video, we're going to be taking a look at how we're going to transition from DSM-4 to 5, specifically highlighting changes that are relative to category and disorder names, as well as talk about the creation of new disorders. Specifically, we're going to focus in on the autism spectrum disorder, which is a new category created in DSM-5, and then take a look at a new diagnostic category altogether called disruptive mood dysregulation disorder. We'll conclude with a brief discussion of how we're going to be incorporating DSM-5 into our electronic medical record between now and the 1st of October. The first and primary change that you're going to notice when you look at DSM-5 is that there's no longer a designation of axes 1 through 5. And when I researched the reasons why they made this change, this is the comment that I came up with consistently. And that was, there's no scientific evidence to support an axial distinction across disorders. I find that kind of odd because I found axis 1 through 5 to be very helpful. Other changes that are relative to DSM-5 from DSM-4 are specific just to name changes. And so a couple of those are these. We are going from using the term not otherwise specified to not elsewhere classified. A general medical condition under DSM-4 is now going to be called another medical condition under DSM-5. Gender identity disorder has been changed to gender dysphoria, and dysthymia has been changed to persistent depressive disorder. And as you review these changes from DSM-4 to DSM-5, you'll find specific to gender dysphoria and persistent depressive disorder that the diagnostic criteria hasn't changed at all. The only thing that's really changed relative to these two disorders is the name. Some more significant kind of changes that we notice primarily involve the way that we categorize these disorders and the way that we kind of specify lengths of time. For example, bereavement under DSM-4, if bereavement lasted for 2 or more months following the death of a loved one, you could have the client or patient diagnosed with a depressive disorder. Under DSM-5, there's now a recognition that 2 months was not enough time and that it should be closer to 6 months. As you know, in some cultures in the world, you're not allowed to stop grieving the death of a loved one until a year has passed. So this is seen as a positive movement and more of a recognition of social and cultural kind of norms around the world. Catatonia used to be the exclusive province of schizophrenia. But now there's a recognition that catatonia can happen in a wide range of different disorders, including autism. So you'll find that within the separate diagnostic categories that catatonia is frequently a specifier that's allowed. Substance abuse and dependence has been replaced in DSM-5 by what we refer to as substance use disorders. And the way we specify a substance use disorder is whether the problems that it's causing are mild, moderate, or severe. Now you're going to see that mild, moderate, and severe are also relative to just about every other diagnostic category in DSM-5. There's a movement towards specifying the level of impairment for each individual disorder. In DSM-4, you couldn't have a substance dependence unless you had the presence of tolerance and withdrawal. Tolerance and withdrawal are no longer mandatory criteria for a substance use disorder. Tolerance and withdrawal still exist within the diagnostic set for a substance use disorder, but it's not a mandatory element anymore. What we used to see in Axis 4, specific to psychosocial and environmental problems, is now being replaced by an expanded set of V codes. GAF under Axis 5 no longer exists in DSM-5. What the American Psychiatric Association is recommending is the use of the World Health Organization HUDAS-2. Now this is a 26-item pen and paper kind of an assessment that you give to a client, and it fairly accurately will describe for you, giving you a numerical designation of the level of functionality that an individual has. It'll give it to you rather quickly. It has very good reliability and statistical analysis data backing it up. Not sure which way the state's going to go at this point, but between now and the 1st of October they will have that decision made up. But the main point here is that the GAF is no longer used. It really was a very subjective kind of an assessment tool. One of the reasons they got rid of that was that there really wasn't a lot of inter-rater reliability around the use of the GAF. In other words, 5 clinicians would evaluate the same clinical presentation and come up with a completely different GAF. So that's one of the reasons why it's been discontinued. So some category changes also. So the category of disorders usually first diagnosed in infancy, childhood, or adolescence has been changed in DSM-5 to just simply neurodevelopmental disorders. Under neurodevelopmental disorders, we've gone from calling a category mental retardation and changed it to calling it an intellectual disability. So we've gone from the use of the term mental retardation to the use of intellectual disability. Intellectual quotient, or the IQ, is also losing favor as a determinant of intellectual disability. Now we need to move on to some categories that have some more significant changes noted to them, specifically mood disorders. Under DSM-4 we had a category called mood disorders, and under that category we had bipolar and depressive disorders. Moving towards DSM-5, we're no longer going to have a category called mood disorders. We're going to have 2 separate categories, one of which would be called bipolar and the other depressive. And this is a recognition that these 2 disorders are distinctly different and should be diagnosed and treated separately and distinctively differently. So when we look at a bipolar 1, again, you'll note that the diagnostic criteria for a bipolar 1 disorder has fundamentally not changed. But what has changed is the way that we describe it. We can again describe the problems that it's causing, or the set of symptoms, as mild, moderate, or severe. The rest of this is unchanged. We can still specify with and without psychotic features, whether or not it's in partial, full remission, or if it's unspecified. Whether or not the current or most recent episode is hypomanic. So these haven't really changed. But what has changed is that this is a category in and of itself, and we're now designating the problems that it causes as either mild, moderate, or severe. We can talk about whether or not the most current episode is mild, moderate, or severe, with or without psychotic features, and so that hasn't changed as well. Again, the most important thing to recognize is that we're looking at the degree of problems that, or functional impairments that these disorders call, designating them mild, moderate, severe. We still have a bipolar 2 disorder. The diagnostic criteria is set still the same. We still want to be able to know whether or not it's a hypomanic or depressed most recent presentation. Cyclothymic disorder is the same thing. It's not changed. All right, a bipolar disorder due to another medical condition is exactly the same in DSM-5 as it was in DSM-4, and the specifiers remain fundamentally unchanged. Now we come to the depressive disorders category. Again, a separate category in and of itself, no longer under the category in DSM-4 called mood disorder. In DSM-5, it is a standalone disorder unto itself. This is where we see a brand new diagnostic category that has been created in DSM-5 that did not exist in any previous DSM, and that's disruptive mood dysregulation disorder, which we'll talk about in just a few minutes. So under major depressive disorder, you see that you can still have a single episode, a recurrent episode. Again, you're going to find the problems being delineated as either mild, moderate, or severe. The criteria for major depressive disorder is still exactly the same in 5 as it was in 4. You still have the ability to designate psychosis and what level of remission an individual might be in. And that's irrespective of whether it's a single or a recurrent episode. We still have persistent depressive disorder. Fundamentally the same thing as dysthymia. They just decided to change the name, but the diagnostic criteria are exactly the same. We still have premenstrual dysphoria disorder, medication-induced, and depressive disorders due to another medical condition. None of this has changed. The only thing that's really changed in relationship to these 4 subcategories is that dysthymia is no longer in favor, if you will. It's gone, and now we're using persistent depressive disorder. In DSM-4, we had a category called attention deficit and disruptive behavior disorders. That has been changed. The category of attention deficit disruptive behavior disorders has gone, and it's been replaced by individual categories that have to do with ADHD and disruptive or impulse control disorders. The criteria set for ADHD is fundamentally unchanged with 2 exceptions. There's now a recognition that this disorder can happen in adults and that the diagnostic criteria is 1 less symptom for an adult than it is for a child. Changes relative to child ADHD is that symptoms now have to be appeared before the age of 12 instead of age 7 as we found under DSM-4. There's a new category called disruptive impulse control and conduct disorders. And we have the old diagnostic sets relative to oppositional defiant disorder, intermittent explosive disorder, conduct disorder, pyromania, and kleptomania. One of the primary reasons for the shift from an exclusive behavior disorder that includes both of these 2 under 1 category is that these are 2 distinctly different disorders and need to be recognized as such. The treatment sets for these and the onset is completely different. Anxiety disorders have also been changed. So under DSM-4 we had a general category called anxiety disorders, and under DSM-5 that's gone. And it's been replaced by 4 separate individual categories. The first of which is the familiar anxiety disorders. There's still such a thing as anxiety. It still contains panic, agoraphobia, specific phobia, and social phobia, but it's now in its own unique individual subset. The next is obsessive compulsive and related disorders. Again, this is just a category change. It still contains the same subcategories. The diagnostic criteria is exactly the same as it was from 4 into 5. We have a new category here called trauma and stressor-related disorders. And so the category is new, but the subsets of diagnostic categories is exactly the same. So we still have acute stress, PTSD, reactive attachment disorder, disinhibited social engagement disorder. Diagnostic criteria is still the same, but now we have a recognition that this category is a standalone category, primarily in recognition to the recent work done around trauma, also around the diathesis stress model that postulates that genetic factors are primary predeterminants of a lot of disorders, with trauma or emotional disruption being the triggering event to cause the genetic condition to be manifest. We still have adjustment disorders, but they're in their own standalone category. And again, we can still designate those adjustment disorders the same in 5 as we could in 4. Depressed mood, anxiety, and so on. Here's a little bit bigger change. In DSM-4, we had a category called pervasive developmental disorders. And under pervasive developmental disorders, we had 5 different subsets: autism, Rett's, Asperger's, childhood disintegrative disorder, pervasive developmental disorder, not otherwise specified. These diagnostic subcategories are gone in DSM-5. Pervasive developmental disorders are now called autism spectrum disorders. And so there are no longer individual diagnostic sets and diagnostic codes relative to these 5 conditions. And one of the reasons why they went away from being able to call these subsets specific diagnostic categories is that research has never been able to demonstrate inter-rater reliability on the criteria for these 5. And so because we're not able to demonstrate inter-rater reliability, in other words, you give a clinical presentation to 10 different clinicians and you may get 10 different diagnostic responses. So that's gone and it's replaced with autism spectrum disorder. Now what the research shows and what the American American Psychiatric Association has demonstrated is that if someone was previously diagnosed with one of those 5 diagnostic categories, that they're still going to meet criteria for the new autism spectrum disorder. What we're looking here in autism spectrum disorder is a way to designate the level of support that's required. So we have 3 different levels based on clinical presentation, from minimal support to substantial to very substantial support. And these are demonstrated as they occur across 2 different spectrums, social communication and restricted repetitive behaviors. And so I have 3 different levels from low to high that demonstrate in the language which particular level that an individual belongs in. So an individual could potentially be in level 3 requiring very substantial support around social communication, but requiring only substantial support on restrictive repetitive behaviors. So just because an individual is in level 3 doesn't mean that their social communication restricted repetitive behaviors belong in that level. Each of these 2 can be designated on the degree of support that's needed. When you look at specifiers for the autism spectrum disorder, we're looking for whether or not there's an accompanying intellectual impairment, a language impairment, in association with another medical or genetic condition. For example, Rett used to be a standalone diagnostic category in and of itself, but now it's a subset of how we describe another genetic condition. Okay, just the same way we used to under DSM-4 indicate that someone also had Fragile X or that it was due to Down syndrome. We can also specify if there's another neurodevelopmental or mental disorder, and we can also specify whether or not it's with catatonia. So when we go to record this, and the nice thing about the system that we have with our electronic medical record is that we're going to be plugging in data. And this data is going to come out in a document that's going to let us know, or let the reviewer know, what the specifier is, what the level of support needed is, and whether or not there's an accompanying language impairment. For example, one example of how this might be presented in a document after an input into an electronic medical record is it might read, autism spectrum disorder with Rett syndrome, requiring very substantial support for deficits in social communication, requiring substantial support for restricted repetitive behaviors with accompanying language impairment. In this case, primarily no intelligible speech. If catatonia is present, then the system would simply write that catatonia is associated with an autism spectrum disorder. Now we come to the brand new category of disruptive mood dysregulation. This is a brand new diagnosis, and it exists under the depressive disorders category. It was created out of a concern that far too many children were being diagnosed with a bipolar disorder. Primarily due to the overuse or the overinterpretation of irritability and extreme episodes of behavioral dyscontrol. So this was created out of a reaction to concern about the number of children that were being diagnosed with a bipolar disorder, a concern that there might be another disorder that better describes the condition that they have, and also points to a different direction as far as treatment goes than your prototypical mood disorder. Some people believe that because we've pulled this out of the bipolar disorder realm, that as a child progresses in age and maturity, that they will basically phase out of a disruptive mood dysregulation disorder and develop a bipolar disorder as they age. This is not being borne out by the research. What typically happens to kids as they mature from the disruptive mood dysregulation disorder is that what they do develop are more unipolar depressive disorders and anxiety disorders. And as we all know, what also goes along with those are substance use disorders. So we're not looking at this becoming a precursor to bipolar disorder. So let's take a look at some of the diagnostic criteria surrounding the disruptive mood dysregulation disorder. So what we see here is a severe and recurrent temper outburst manifests verbally and physically by verbal rages and behavioral physical aggression towards people and property. Now this is out of proportion to the situation. This is inconsistent with developmental level. In other words, this is not the terrible twos. These temper outbursts occur on an average of 3 or more times per week. And the mood between outbursts is very irritable and angry. So we might have an explosion, and we would have, following that explosion, the baseline would still be very angry and irritable. These criteria must have been present for 12 or more months, and throughout that time there cannot have been a period of 3 or more consecutive months where the symptoms for criteria A and D were not met. Criteria A and D are present for at least 2 or 3 different settings: home, school, and out in the community with peers. The diagnosis should not be made for the first time before the age of 6 or after the age of 18, but typically what we see is the onset of these symptoms prior to the age of 10. This is not a condition that has manifestations of mania or hypomanic activity. If you find hypomanic or manic activity that lasts for more than 1 day, there needs to be a consideration for that disorder in addition to the dysregulation mood disorder. Okay. These clinical presentations are not better explained by a major depressive disorder or any other mental disorder, and they're not attributable to a substance use induced condition. So what we see here are 2 things. We see very frequent temper outbursts, and in between temper outbursts there is a very irritable and angry mood. Okay? These are present most of the day, nearly every day, noticeable by everyone that comes into contact with the child. Differentiating this disorder from others can be a bit tricky, especially since this is a brand new disorder. We cannot diagnose a bipolar disorder and a mood dysregulation disorder at the same time. What we typically do not see in a mood dysregulation disorder are periods of mania that last more than 1 day, or hypomania for that matter. And what we also do not see is an elevated or expansive mood and grandiosity in a child that has a mood dysregulation disorder. Oppositional defiant disorder is, at this point, considered to be very rare with children that also have a disruptive mood dysregulation disorder. But if both criteria appear to be met, in other words, a kid appears to be meeting criteria for an oppositional defiant disorder and a disruptive mood disorder, then we simply should be diagnosing the disruptive mood dysregulation disorder. We should not be diagnosing both at the same time. ADHD, major depressive disorder, anxiety disorders, and autism spectrum disorders can be diagnosed at the same time as a disruptive mood dysregulation disorder. However, should not be done if the presentation of the mood dysregulation disorder is exclusively seen during a depressive episode, during an anxiety episode, or when an autistic child's routines are disrupted. So when autistic child's routines are disrupted, the only time they show this behavior, we should not be also including a mood dysregulation disorder on top of the autism. What we see typically is that the symptoms of ADHD around impulsiveness and disorganized attention are not present during a mood dysregulation disorder. Now, some people would think this sounds an awful lot like an intermittent explosive disorder, but you have to remember that in an intermittent explosive disorder, you have a little bit of a reprieve in between episodes. With the disruptive mood dysregulation disorder, you have the blow-up, but you do not get the reprieve. The inter-episode behavior is quite irritable and angry. We should not be making the diagnosis of an intermittent explosive disorder and a mood dysregulation disorder at the same time. And again, just to kind of summarize, this is a spin-off out of a concern about the number of people being diagnosed with a bipolar disorder, and that we cannot diagnose a bipolar disorder or an intermittent explosive disorder at the same time as a disruptive mood dysregulation disorder. Okay, so that's some of the changes, and again, this was intended to just be a highlight of those changes. As we transition from DSM-4 to DSM-5, Robin Trush and her staff are going to be rolling out changes in the electronic medical record incrementally. It'll be rolled out slowly so that we'll have an opportunity to adjust. By the time we get to the 1st of October, we should be fully aware of the changes and had time to practice these changes. So we've come a long way from 1840, for example, when the primary diagnostic tool was phrenology. Thank God we no longer feel the bumps on people's heads to determine a diagnostic category. We've moved into functional MRIs and genetic coding. We've come a long way. Some people get concerned about changes in DSM, but you have to remember every time that there's a change in the DSM, it means we're making progress. We've come a long way since phrenology, and we've got a long way to go. So between now and October 1st, your task is to become familiar with the changes. As Robin's staff roll out changes in the electronic medical record, there'll be more trainings that will be offered. And this will be an opportunity for you to report areas of conflict or concern with the new electronic medical record designations for DSM-5. Report those to Dr. Callison or the clinical directors. The hope is that we can iron this out completely, or as nearly as possible, by the time October 1 rolls around. And that concludes our presentation, and thank you for your attention.